MRCPology channel for a quick review, understanding, and revision of the topic. Imagine a young woman with obesity and recent weight gain who presents with daily headache, brief episodes of visual dimming, and a whooshing sound in her ears. Fundoscopy shows bilateral papilloedema, but brain imaging reveals no mass lesion or hydrocephalus. The key question is whether this represents idiopathic intracranial hypertension or a secondary cause of raised intracranial pressure. Idiopathic intracranial hypertension, or IIH, means raised intracranial pressure without an identifiable structural, vascular, or biochemical cause. Brain imaging must show no mass lesion or hydrocephalus, and the cerebrospinal fluid composition must be normal. To understand IIH, think in 4 boxes: pressure regulation, clinical consequences, diagnostic exclusion, and protection of vision. First, consider pressure regulation. The core problem is impaired regulation of cerebrospinal fluid pressure. Obesity and recent weight gain, particularly central obesity, may increase intra-abdominal and intrathoracic pressure. This reduces cerebral venous drainage and raises pressure within the dural venous sinuses. Raised venous sinus pressure then reduces cerebrospinal fluid absorption at the arachnoid granulations. Reduced cerebrospinal fluid absorption leads to raised intracranial pressure. The raised pressure can further compress the transverse venous sinuses, increasing venous resistance and creating a vicious cycle. Obesity-related hormonal and metabolic changes may also contribute. Dysregulation of androgens and glucocorticoids may increase cerebrospinal fluid production or impair its absorption, although the precise mechanism is not fully understood. The pressure is transmitted through the cerebrospinal fluid surrounding the optic nerves. This disrupts axoplasmic flow within the optic nerve heads, causing optic disc swelling and papilloedema. Persistent papilloedema can damage the optic nerves and produce irreversible visual loss. This is why the priority in IIH is not simply controlling headache, it is protecting vision. The typical risk profile is a woman of reproductive age with obesity or recent weight gain. Central obesity appears particularly relevant. Polycystic ovarian syndrome is commonly associated with IIH, but it has not been proven to be an independent risk factor. MRCP trap: do not diagnose idiopathic intracranial hypertension until secondary causes have been excluded. Tetracycline antibiotics, vitamin A derivatives, lithium, growth hormone, and corticosteroid withdrawal can produce secondary intracranial hypertension. Cerebral venous sinus thrombosis is another critical alternative diagnosis that must not be missed. Now consider the clinical features by linking each symptom to its mechanism. Headache occurs because raised intracranial pressure causes traction and distension of pain-sensitive structures, including the dura and venous sinuses. The headache may be daily and can resemble migraine, so the headache phenotype alone does not establish the diagnosis. Transient visual obscurations are brief episodes of visual dimming, often triggered by standing, bending, or changing posture. They occur because raised pressure around the optic nerves temporarily interferes with optic nerve function. Persistent papilloedema can cause progressive visual field loss, classically beginning with enlargement of the blind spot and peripheral field impairment. Raised intracranial pressure can stretch the 6th cranial nerve as it travels through Dorello's canal near the petrous apex. This produces an abducens nerve palsy, causing impaired eye abduction and horizontal diplopia. The diplopia is usually worse when looking towards the affected side. Pulsatile tinnitus is commonly described as a rhythmic whooshing sound, synchronous with the heartbeat. It is thought to result from turbulent venous flow associated with raised venous pressure or transverse sinus narrowing. The key clue is papilloedema in a patient with symptoms of raised intracranial pressure. However, papilloedema is not synonymous with IIH. It is a sign of raised intracranial pressure and demands investigation for structural lesions, hydrocephalus, and cerebral venous sinus thrombosis. Diagnosis is therefore a process of exclusion. Magnetic resonance imaging of the brain should be combined with magnetic resonance venography. Imaging is used to exclude a mass lesion, hydrocephalus, Chiari malformation, and cerebral venous sinus thrombosis. Imaging may also show features that support raised intracranial pressure, including an empty or partially empty sella, flattening of the posterior globe, distension of the optic nerve sheaths, and transverse venous sinus stenosis. These radiological signs support the diagnosis, but they are not diagnostic by themselves. Transverse sinus stenosis may be either a contributor to raised pressure or a consequence of it. Once imaging has excluded a contraindication, lumbar puncture is performed. The cerebrospinal fluid composition should be normal, but the opening pressure is elevated, typically above 25 centimeters of cerebrospinal fluid in adults. Opening pressure must be measured correctly. The patient should be in the lateral decubitus position, relaxed, with the legs not excessively flexed, and without performing a Valsalva maneuver. Poor technique, anxiety, breath holding, or excessive leg flexion can falsely elevate the reading. MRCP trap. An isolated raised opening pressure does not automatically diagnose IIH. The result must fit the clinical picture, imaging findings, and ophthalmic assessment. Every patient requires careful assessment of visual function. This includes visual acuity, pupillary responses, fundoscopy, optical coherence tomography, and formal visual field testing. Visual acuity may remain normal until relatively late, so formal visual fields are essential. The urgency of treatment is determined mainly by the severity and rate of visual deterioration. Now move to treatment. The main disease-modifying treatment is weight loss. Weight reduction lowers intra-abdominal and venous pressure, improves cerebral venous drainage, and improves cerebrospinal fluid pressure dynamics. This reduces intracranial pressure and papilloedema. Acetazolamide is the main pressure-lowering medication. It inhibits carbonic anhydrase within the choroid plexus, reducing bicarbonate-dependent cerebrospinal fluid production and therefore lowering intracranial pressure. Common adverse effects include paresthesia, fatigue, gastrointestinal disturbance, renal stones, hypokalemia, and metabolic acidosis. Electrolytes and renal function may require monitoring. A history of sulfonamide hypersensitivity requires careful assessment rather than an automatic assumption that every patient will cross-react. Topiramate may be helpful when the headache has a migraine phenotype or when weight reduction would be beneficial. It provides weak carbonic anhydrase inhibition, appetite suppression, and migraine prophylaxis. Its adverse effects, including cognitive slowing, paresthesia, and teratogenic risk, must also be considered. Repeated lumbar punctures are not a good long-term strategy because cerebrospinal fluid is rapidly replaced. They may occasionally provide temporary pressure relief while definitive treatment is being arranged. Sight-threatening disease is an emergency. Rapidly progressive visual loss requires urgent specialist intervention. Surgical options include cerebrospinal fluid diversion, usually with a ventriculoperitoneal shunt, or optic nerve sheath fenestration, depending on the pattern of disease and local expertise. Venous sinus stenting may be considered in selected patients with significant venous sinus stenosis and an appropriate pressure gradient, but it is not routine first-line treatment. Headache often requires separate treatment even when intracranial pressure is being addressed. Many patients have a migraine-like phenotype, and migraine-style preventive therapy may be required. Analgesic overuse is common and can perpetuate chronic daily headache. Do not confuse improvement in headache with protection of vision. Headache severity does not reliably reflect the degree of papilloedema or the risk of visual loss. Management decisions must therefore be guided by formal visual assessment rather than symptoms alone. If you remember one thing, remember this. IUH is a diagnosis of exclusion in a patient with raised intracranial pressure, normal cerebrospinal fluid composition, and no structural or venous cause on appropriate imaging. And the major preventable complication is permanent visual loss. Quick recall. A woman with obesity presents with headache, pulsatile tinnitus, and papilloedema. Magnetic resonance imaging shows no mass lesion, but magnetic resonance venography has not been performed. Why should lumbar puncture not be the final diagnostic step at this stage? The answer is that cerebral venous sinus thrombosis must first be excluded with venous imaging because it can closely mimic idiopathic intracranial hypertension and requires different treatment. A patient with confirmed IOH reports that her headache has improved, but formal visual fields show rapidly progressive peripheral visual loss despite medical therapy. What is the next management priority? The answer is urgent sight-preserving surgical treatment, such as cerebrospinal fluid diversion or optic nerve sheath fenestration, because headache improvement does not exclude ongoing optic nerve damage. Do subscribe to the channel for further videos.